Good morning, everyone. I accord a very warm welcome to all the participants who've joined us today morning for this session of Code with Chris Dents. And today we have another very important topic that is platelet-rich fibrin and its applications in dentistry. Since the time we've discovered regenerative potential of the periodontal ligament cells, scientists have been trying to recreate the spatio-temporal relationship of the various cells, molecules, and the interstitial substance, which is present during the time of tooth development. But still, true regeneration has been an elusive goal, and various methods have been used, including bone grafts and GTR membranes, growth factors, and all. But still, we haven't seen very good results with most of the agents that are used. And we all know that platelets have a very important role in healing and in hemostasis. So it was around 1970s that we discovered that platelets have a lot of growth factors, and they have a very important role in the angiogenesis and healing of the blood vessels and new capillary formations. So various platelet concentrates have been in use from that time to try and attain regeneration. So platelet rich plasma is one, and the newer generation platelet rich fibrin has been in use recently. And to shed more light on this topic of platelet rich fibrin and its various applications in dentistry, we have a very special guest here today with us, Dr. Jerry Mammen, who will be telling us more in detail on this topic. And to introduce Dr. Jerry, I would like to request Dr. ABM Thomas, our principal, to please introduce the speaker.
Good morning, everyone. And Jerry is from the batch of 2003, and he was roll number 28, correct?
Yes, sir.
so, so he was the dynamic group of young people who came. He was one among them. So, and he wanted to be always here, but God has his own way, and he's been to different places. He came for post graduation, and he was here for 2 months, I think. Then he did his
Yes, sir.
graduation from Calicut Government Dental College and in periodontics through All India seat. And afterwards, he worked in different places. He had a brief stint in Liberia too, no, Jamaica too.
Jimmy.
So he was now for the past, I think, 3 years.
6 years, sir.
Oh, 6 years. Okay, past
Yes,
6
sir.
years. He is there in Seychelles, and is a big man there in Seychelles, along with his colleague, Dr. Ashwin Sakaria, and there are more alumni with him. And so CDC has a good representation in that country. And so we are pleased to have him here today with us. I'm sure it will be an enriching experience for the CDC crowd and for all the alumni crowd. And we welcome once again Jerry, our own, to our midst. Thank you.
Thank you so much, sir. Those kind words. Thank you so much.
Yeah, I think over to Jerry.
Okay. Thank you. Without much delay, we'll start with the presentation. I'm just going to share my screen. Is the screen clear?
Yes.
Okay. So very good morning to all. The topic from very good morning to all from Seychelles. So this is how this island looks. There are 3-4 small islands around our main island where we work. So we have one main hospital in the main island Mahe, and then 2 more hospitals in the smaller islands, that is Prale and Ladig. Like sir said, now we have a small CDC group here. So we have 2 oral surgeons, we have 1 periodontist, 1 pedodontist, and 1 orthodontist also, all from CDC. Okay, the topic for today is platelet rich fibrin. So I was speaking with Dr. Joe, and he said we have interns, we have postgraduates, and then we have even students coming for this lecture. So my aim of this lecture is to basically give you an idea of what platelet-rich fibrin is and how to use it, or how can we use it or make it a daily practice. Okay, because it is a very simple and effective procedure to give you some very good results, whereby the patients will be very happy with the results. More than regeneration, I would say patient comfort and the healing results of the soft tissue are excellent with platelet-rich fibrin. Okay, so let's first see what we are going to talk about today. The content will be what PRF is. Then, like Ritu ma'am said, what is the evolution of platelet concentrate? So how did we come into this? What all are the modifications that have come into platelet concentrates? What are the biological characteristics? What is the significance of each cell, the membrane in it? How does it play a role in regeneration and healing? Then the preparation techniques. I've prepared 2 videos also with the kit that we have here. And then what are the benefits, limitations, its application in dentistry, and what application now they are using it in the field of medicine also. Just an overview of field of medicine. Okay. So to start with, what PRF is. PRF stands for platelet-rich fibrin. It is a 2nd generation platelet concentrate. So it is the latest, generation that has come for platelet concentrate. The first one was your PRP. We'll see in, more in detail. This platelet-rich fibrin was introduced by this person known as Shukroon in 2001. In his pain clinic that he has in France. That is where they introduced this concept of PRF, the technique, everything was introduced by this guy. And what is the concept behind PRF? What are we trying to do? So basically, when we take blood in the test tube, our aim is to concentrate all those useful cells for us, which helps in healing, which helps in regeneration, and which gives you growth factors, whereby we are expecting some kind of tissue growth, hard tissue growth, soft tissue growth, coverage of recession there. So basically it's based on the density of the cells, which cells are heavier, which cells are lighter. You're going to separate them based on the centrifugation process. So you centrifuge them, and based on the density, you're going to separate the lighter cells to the top and heavier cells at the bottom. Okay, so we'll see all that. So this is a basic overview. Okay, now coming to the evolution of platelet concentrate. Okay, so this most of my presentation is from a textbook by Richard Mirion. It's an excellent textbook for PRF. People who are interested in learning more about PRF, it's an excellent textbook. In my references, I've given about it also. So you can download that book, and it gives you in-depth detail of the procedures, the theory behind it and everything. Okay, so to start off, initially the platelet concentrates were started as PRP, that is your platelet rich plasma. Okay, now it was started in 1998 by Dr. Marks. Okay, now there were a lot of advantages. Basically, you're trying to concentrate all these platelets into that area, whereby it will release certain growth factors and you will have better healing. But there were a lot of drawbacks for PRF. Okay, one of the major drawbacks was we were adding anticoagulants like calcium chloride or something. You are adding to the procedure, whereby you were not getting a pure autologous graft. That means now there were additives in it, and studies showed that these additives were actually hampering the outcome of the result. Okay, the second biggest problem with PRP was that the procedure was extremely long. So while you're doing surgery, you needed a second hand to prepare the PRP, because it had multiple steps, and the procedure lasted, I think, somewhere around 30 to 45 minutes. So I have personally not done PRP. I've not even seen it. I've only heard about it. So when I joined for PG in 2012, in our surgery in Perio in Calicut, an extensive study was going on PRF. There were a lot of theses going on, and so at that time when I got introduced to PRF, the PRF that was done there was the LPRF, or normally what we call as the PRF. The L stands for leukocyte. So leukocyte PRF. So from PRP, the biggest jump that we made was from PRP to PRF. So PRP stands again platelet rich plasma. So it's a liquid. So even for periodontal regeneration in different sites, you could not apply this because it was in liquid form. The application also was hampered because of the consistency of the plasma that was there. So the modification that was made was the LPRF or the PRF. Now, what was different in this? The biggest difference was that they stopped using any kind of anticoagulants. So it was purely autologous. It was purely autologous. You didn't have any foreign body reaction. You didn't have any additives in it. So that was the biggest advantage of PRF. The second advantage of PRF was, or LPRF was, that it was, the consistency was like a gel-like consistency. So what you could do is that you could manipulate with this in certain ways, whereas you could pack certain defects, you can mix it with bone graft and use it. So that was the biggest advantage of PRF as compared to PRP. Okay, now why this LPRF was given is that the concentration of leukocytes in PRF as compared to PRP was much higher. We'll understand why, what is the significance of your leukocytes or WBC in getting incorporated into the PRF. Okay, so I hope PRP and the basic PRF is clear. Now, over the next 10 to 15 years, that is from 2001 onwards till 2020 and present, there are a lot of modification that has been happening. So if you see this chart here, you can see from LPRF, you have APRF, APRF plus, IPRF, and now you have the BioPRF. And now with the modification in BioPRF, you have extended PRF, ALPRF. There are a lot of things that are coming in. There's so much more to learn. Okay, so in a college setup, you have the opportunity, you have your teachers around you to gain all these knowledge and start using it in your clinical practice. So now when you see LPRF, as we go towards the latest thing, the only difference, or the difference that you can note, is that see the amount of revolutions per minute that are decreasing little by little. Can you see that? This is 2700 RPM for 12 minutes. Then it became 1300 RPM for 14 minutes. Then it became 1300 RPM for less time, 8 minutes, 700 RPM, 3 minutes. Like that, it kept changing. So what is the change that is there from LPRF to APRF? It is the concept of low speed centrifugation. So once the LPRF was introduced, a lot of research was done. And then they realized that not all cells are getting incorporated into the PRF gel. Because, like I said, what is the concept behind this? The concept is to bring all the denser cells at the bottom and the heavier, lighter cells to the top to get incorporated. You have three basic cells. You have your platelets, you have your leukocytes, and you have your RBCs. RBCs are the heaviest, followed by your WBCs, and then you have the platelets. So imagine if this is a test tube and you're filling the test tube with blood, and then you are centrifuging it at a fixed angle. You are expecting cells that are light here to come up when the centrifugation, it has a very high speed. It doesn't get enough time for these cells to go up. So in LPRF, the problem was all cells or all platelets and WBCs were not getting incorporated into the gel. What are we looking for to get all these cells there so that we have advantage? If we are not getting that, then the results will be decreased. So the concept of low speed centrifugation was introduced for one main thing, to make sure that all the lighter cells have enough time and the speed is maintained in such a way that they can travel up and get incorporated into the gel. So that is how APRF and APRF plus was introduced. Now, what does A stands for? It is an advanced form of PRF. So A stands for advanced PRF, and APRF plus is advanced PRF plus, where they have reduced the time also of the centrifugation. Now, more and more studies were going on, and then they reached something known as IPRF. IPRF is nothing but a PRF that is in a liquid form. So it's something like a PRP, but the advantage here is that you're trying, because of the centrifugation, low speed centrifugation, you're incorporating more platelets and WBCs into that liquid area. Okay, and what do you use for? You use this, take it out, and you can inject into certain areas. For example, those who have joint pains, they're injecting TMJ. Now a lot of studies are going on, they're injecting the IPRF into the TMJ. Facial rejuvenation, I've seen a lot of our alumni doing IPRF injections within the face and doing facial aesthetics. So that is the advantage of IPRF. Then once this APRF plus and IPRF was done, then came the concept of BioPRF. What is BioPRF? The only difference is that now from a fixed angle, before the centrifuge, the test tube was at a fixed angle like this. For BioPRF, the centrifuge has been, or the test tube has been made horizontal, so that once the centrifuge starts spinning, it becomes horizontal, whereby it's going to push more cells into the gel area. Thereby, we are going to concentrate the maximum number of cells in that region. So that is your BioPRF. Okay, so I think everybody got an idea of what PRP is, how we evolved from PRP to LPRF, APRF, APRF plus, IPRF, and your BioPRF. So at the bottom, you can see the year-wise progression that has been made into the advancement in PRF. Okay. So now what does the biological characteristics? So when you spin, this is done in a fixed angle, because you can see an angle that has been created here. If you're using a horizontal centrifuge like a BioPRF, you won't get the slant. It will be equal because the cells will travel towards the center. So that's one way to, even seeing the test tube, you can tell whether you have used a BioPRF or a horizontal centrifugation machine or a fixed angle one. So here you can see 3 layers that are formed after the centrifugation. This is the top layer, that is the platelet poor plasma, which is not much important to us. This area is, can you see this gel-like consistency that has formed? That is the most important area for us, because this is the area that has incorporated all the cells and the matrix that has formed. So what is this area consists of? This area consists of certain cells, a provisional matrix that has been formed, and lot of growth factors. How did the matrix form? We studied that from PRF onwards, we are not using any additives, no anticoagulants. So as soon as you pour or you take blood into the test tube, the blood comes in contact with the glass surface, and once you start centrifuging, they start to coagulate. And this is by the normal mechanism. So your fibrinogen gets converted into fibrin, and you have the fibrin clot that is formed, which with all the cells that are getting incorporated into it. What are those cells that we want here? We want our platelets and we want our leukocytes there, your WBCs there. These are the 2 important cells that has to be incorporated into this matrix, which is your fibrin matrix, along with the growth factors that are released by these cells. Which are the most important ones? Your vascular endothelial growth factor, which is important in angiogenesis, because it is the most important thing that we need while healing is the blood flow, blood vascularization or blood supply. Without that, you do anything, it's going to fail, because you need blood supply there, and you need the cells to come to that site and to cause all kind of regenerative changes happening there. Then you have your platelet derived growth factors, which is required for recruitment of new cells into that site. For example, you're placing it in a bone, like an extraction socket. You have walls on all sides. The PDGF will attract more cells from there, osteoblastic cells from there. It will come there and it will lay bone. So you have bone fill there. Then you have the TGF beta, which is again towards the end of the healing phase. It is required for proliferation of the cell and forming the final matrix for fill of the defect. Okay, so basically you have the advantage of PRF is that it's by a natural process, the clot is formed, which forms a 3-dimensional clot where all the cells are trapped in it, all the growth factors are trapped in it, and they slowly release these growth factors over a period of time. There are a lot of studies that have shown that when they have compared PRP to PRF, the release of growth factors, the number of WBCs and the number of platelets is much higher as compared to PRP. Okay, so that is an added advantage of PRF. And as you move from each advanced stage of PRF, the concentration of your leukocytes and your platelets increase, and the growth factors also increase. So they all add additional advantage while the tissue undergoes healing. Okay. So this is the PRF starter kit we use here. So it is by the kit is introduced by Shukrun itself, which is it is their trademark kit, which is known as the Duo Cot. And then we have one more set with the Maxillo now, which is the Bio PRF kit. So this Duo Cot is a fixed angle centrifugation kit, or a centrifugation machine where you have the test tubes at a fixed angle, whereas the Bio PRF you have at an horizontal angle. So what is the advantage? You have more cells getting trapped there, and it is equally distributed into the PRF gel, whereas in this, more concentration will be at the juncture between the RBC layer and the PRF gel. Okay, the concentration is not as ideal as compared to Bio PRF based on all the studies done. Okay, histological studies done. Now, what does this PRF starter kit contain? So you have all the instruments that are required. So you have the fine scissors, you have the tissue pliers, you have the PRF picker, or you can use this tweezer to pick up from the test tube. Then you have the spatula, you have the condensers for making the PRF membrane if you don't have the plate. And then you have the PRF tray, the PRF bowl, the stand for that, the tourniquet, a butterfly type of IV set that you get with it, with the vacuum and the test tubes for that. The test tubes are also extremely important. Earlier, when we started doing in 2012, we used to do it in a normal centrifuge machine with an open glass test tube. So there are a lot of drawbacks for that, because the blood already starts clotting and you're not going to get all the cells in the PRF area into the gel. Whereas in this, it's a vacuum tube. So once you insert this tube into the vacuum, it automatically, the blood gets drawn into it and it is sealed there. Immediately place it into the centrifuge machine and it starts spinning. Okay, now please understand that there are, based on the test tube, there are different types of PRF that are produced. For example, here you can see two colors of test tube. You have the red cap test tube and the green test tube. Okay, so based on the new Bio PRF concept, excuse me, the red test tube is basically meant for making your PRF membranes. Why is it? Because this test tube is it's glass and it's hydrophilic in nature. What does it mean? It will attract the liquid towards its walls. As liquid comes in contact, platelet will come in contact and it will start coagulating. Okay, so when you spin it, you will get a proper membrane or a gel-like consistency you get. But what if you are planning for an IPRF? IPRF, you have to use a hydrophobic test tube. That means it does not attract the blood to the walls, so it stays away. The platelets will stay away and they will clot very less, so you will get a liquid form of PRF in it, where you get the injectable or the IPRF. So the use of test tube is also very important. If you are not aware of that and you start using the green test tube from the kit for making membranes, you will always get liquid. And then you will keep complaining that there's some error. There is no error, because you are using the wrong test tube for the wrong procedure. So that is very, very important. Okay. And then you have the PRF box here. So you can see small white, container like stuff. These are for making PRF plugs. So when we have extractions here, we use this the small thing here to make anyway, in the video, this thing here, this white clot things, they are like small pistons with holes in it. So you can place the PRF into it and then you press the piston into it, it gets compressed and you will get a plug. So you can use that plug. It will become like a cylindrical plug. It will directly go into the extraction socket, and then you can use a membrane to cover the extraction site and suture it. So for guided bone regeneration before implant placement, if you want to preserve the ridge properly, you can use this. Okay, so this is the PRF starter kit we are using here in the dental unit. And with the maxillofacial, they have a Bio PRF, which is one step more advanced than the Shaukran kit. That is the DO PRF. Okay, is it clear till now? Can I keep continuing?
Yes, please go ahead.
Yes, thank you. So now coming to the protocol behind PRF. It's a very simple protocol. You first draw the blood. I think because most of you are in CMC and in oral surgery, I know we have nurses with us. Here we don't have. So we have to draw blood on our own. So initially I used to find it little difficult because here we have little more bulkier people and a little more dark skinned. So what happened is that you tend to miss the draw or the puncture. You try to miss 2-3 times, you try, and then only you get it. So recently what I've done is that I have acquired something known as a vein hunter. So that is a LED lighted device which will help you to actually locate the position of the vein perfectly. So you can actually see the outline of the vein, whether it is tortuous, whether it is straight, inclined, or deeply penetrating into the tissue. You'll get a clear idea, so you'll know exactly where to place. So what my assistant now does is that she places the vein hunter onto the arm, and I can exactly see the position of the vein so that you don't miss it. So if you want to practice, you can buy, it's available on Amazon, and you can buy that. So this is the time for you to learn when you are in your internship and when you're doing your demoship. You can use these devices. It is something new, something nice, something innovative, and you will be confident in yourself to draw blood on your own. The biggest problem I've seen is, as dentists, when we move out and then there is some emergency situation, most of us are not able to get an IV line. So these things later will bother you, because if you're not comfortable in taking or drawing the blood, you will stop doing this procedure. So you have to find ways to make yourself comfortable, get into that comfort zone, make yourself confident, and then go ahead. So draw the blood, that's the first step. This is very easy now because with this butterfly pin, it's very easy to draw the blood. You will immediately see, as you go into the vessel, you will see the blood coming here, and just connect the test tube into the vacuole. It's a pressured this thing, so it will automatically pump in the blood, and you can stop where when it gets full. Okay, so and you can take multiple draws because this is attached to the, not like, because during PG we were using syringes to draw. So this is very easy in that way. Then you load it into your centrifuge machine, whether it's Duo or BioPRF, you load it into that, and then you have a lot of settings in this. Okay, so you have for APRF, you have for IPRF, APRF plus, all the settings are present in this. You don't need to by heart any of the RPM or the time, because everything is preset. Only for if you're studying for your MDS, you have to by heart it. Otherwise, as a clinician, you don't have to worry about it. You have to just place it inside it and then do the procedure and just give it a run. So what I do is that sometimes I need a combination of, when I'm doing a papilla enlargement case, when I want to inject a little bit of IPRF into the tip of the papilla also, what I do is that I take one red test tube and one green test tube and I put it in one setting. But because it's a green test tube, what I've seen is that you balance it, and what I've seen is that in the red one you will get a PRF gel, and in the green one, or it's sometimes blue colored, in the blue one you will get the IPRF. So you can finish both the procedures in one single spin. Okay, and then finally you have the PRF. Okay. So this is a small video, I just recorded it yesterday. You can just see here, we have actually, I've already completed the spin. So you can use the plier, and you can see, you can slowly pull out the PRF membrane. This is the whole kit, the PRF kit, which is provided by the Duocot along with the centrifugation machine. So here you can see clearly the RBCs, which are the heavier cells, which are getting at the bottom, and you have the PRF gel. So when you cut the gel, just make sure that you carry a little bit of the layer of the RBC also, a thin fine layer, because mostly the maximum concentration of your platelets and your leukocytes are going to be at that junction. Okay, so that is the red test tube, and now you can see this is a green test tube from which I have centrifuged it together. So from the green test tube you can take out your IPRF. So it will be in a liquid form, and you can take out the IPRF. This is first just for a demonstration purpose. I've used this. Normally you don't use such big needles, you use more finer needles for this. Okay, so you have now, within a single spin, you are able to achieve both the liquid PRF, and you are able to achieve the PRF, LPRF or APRF for here. So what here I'm going to try to show you is how we make the bone graft. We are going to mix it with the PRF, and like it becomes a gel, and you can use this because it becomes such a good structure. You can actually pack it into the defect. Okay, so you have the instruments for that, and you can mix it. And I've used a very small quantity because these are very expensive bone graft, just to give you a picture how it becomes into a mass. Okay, so you can use this then to place it into the uh, whatever defect site you have, especially you have a 3-wall defect and all, you can place it, pack it nicely. So what the advantage is that you have a bone graft mixed with an autogenous material which has growth factors, which has cells, and which will provide you a good environment which may cause regeneration. Okay, which may provide regeneration. Okay, this is again another video where I'm just going to show you, if you don't have the PRF tray for making the membranes, what we do here is again, you can see the PRF thing. You are just taking it out. Again, you can see the juncture there clearly. Here what we are trying to do is we are trying to make a membrane. Normally perforated trays comes with a heavy steel tray on top of it, which can compress it, and then you will get the PRF membrane. We didn't get that with our set here. So now, because sometimes for gingival recession cases, I commonly use the membrane, and also when I graft any site, instead of using GTR now, I use the PRF membranes. So because GTR is more time consuming and everything, this I find it more easier. So you have these condensers, and you can slowly condense them into the shape that you want. It takes around 2 to 3 minutes maximum to get the nice consistency of a thin membrane, which you can then place onto the site that you want. Okay, so normally it's a different procedure. You have a perforated tray and you have a condenser or a steel condenser, which then goes on top of it. But if you don't have, you can obviously make your own adjustments, and so you can see a nice thin membrane that has been formed, which you can then place on top of your defect. Okay, so based on the size of the defect, the blood drawn should also be in such a way that you get a good membrane. Okay, so now coming to the benefits and limitations. It's a very simple and easy protocol, like I said. Why I'm stressing on this is that as clinicians and as interns and demos we have there, you have an opportunity to do something good. And as PGs, there are a lot of opportunities for your studies, for your thesis. You can bring in a lot of things into this, because there are still so many studies going on. Still, we are not clear of so many areas if you go into the literature. So this is a good beginning, I would say, where you can start using post extraction. Don't go and put it in all extraction socket, but if you have a severely traumatized extraction socket, you can use this, because I'll tell you the benefits. What are the benefits for that, and advantages of you using that. Okay, so first thing is that it's a simple and easy protocol. No use of anticoagulant, so it's purely autologous material. Like I said, it's a combination of cells, 3D fibrin matrix, and growth factors. So when we talk about regeneration, there are a triangle that we talk about, and you have to have these three things. You need to have cells there, you need to have a scaffold, and you need to have growth factor with blood supply. Okay, so if you can provide that, they say that there are chances of regeneration. Again, studies are still going on, and it is less expensive. Now, why I would say that the kit as such is expensive, but it's a one-time investment for us. It's a single one-time investment for us to get a good PRF kit, a good PRF machine, and then start doing your research, your studies. As an institution, you have wide opportunities. Here we are restricted. We are in a very small country with a limited number of patients, and we don't have that much openings here. But when you are in a college setup, when you are doing PG, and when you have exposure to such good faculty there, you should make use of these opportunities to do more research and studies on this, whereby you can come up with new techniques, because like I said, every day new advancements in PRF are coming. So it's comparatively less expensive, because once you buy the kit, everything comes with it, and then only thing you have to order again and again is the test tubes for that. The rest, everything, the blood is cheap. You get cheap backwards now, and then everything is okay. So it's a one-time investment, and the benefits are lots for this. Okay, now coming to the limitations, the working time is slightly less. and the consent for blood draw. Here it's a very big issue for us here. Now we have this machine for almost a year, but till now I've done altogether around 5 to 6 cases. Mostly is because of the patients not giving the consent to draw blood. Okay, so that is very important, and that is one limitation which I would say is there. Okay, now coming to the application in dentistry. So where all can we apply or where we can use PRF? You can use it for periodontal regeneration, especially in an intra-bony defect. Please understand that PRF as such, if you put in a one wall defect or in areas where there's no inner walls, you are not going to get any kind of regeneration. Please do not expect that you put PRF here and you will have full bone there. It's not going to happen. Okay, what I have experienced over during my PG time and now here, it is an excellent soft tissue healer, or it gives an excellent soft tissue healing post your procedure. What I've seen is that when you're using PRF and post operatively, when you call the patient for suture removal itself, mostly when you call the patient for suture removal, you will still see inflammation around that area and everything. But with PRF, it is, I can say, almost half of this thing. Inflammation is almost decreased by half. You don't see that much. This is contributed to the fact of your leukocytes present there. I already said that we have platelets and we have leukocytes. So what does the leukocyte do? Leukocyte or WBCs, what they do is that these cells, we understand that they play a role in infection, preventing infection. They fight against microbials to remove them. So your macrophages, your leukocytes, all of them play a major role in removing the microorganisms from that side. So these leukocytes, basically what do? They prevent infection in that site. So it's like what you're giving antibiotics locally at that site. You are now loading the surgical site with all kinds of WBCs which can fight infection. The second thing is that these leukocytes play a major role in immune regulation. They release a lot of growth factors and lot of immune regulatory factors like your interleukins, TNF. They play again a major role in healing and in providing a fast healing. Okay, so that is the most important part here, and that is why more studies have been done to concentrate the leukocytes into the PRF membrane, whereby we can make use of this immune reparative role of your leukocytes in healing. Okay, along with that, there are studies that have shown that whenever you use any biomaterials and leukocytes are present there, the integration of the biomaterial with the host tissue is much more as compared to when when leukocytes concentration are less. Okay, so basically it helps in an integration of your biomaterial with your host tissue. Very, very important. So it can be used in intrabony defects, mostly in your 3-wall defects, so that you have walls on all sides. You're placing the membrane there, and then you PRF plug there and a membrane on top. So basically you're preventing the epithelium to come inside. At the same time, you're giving growth factors and cells there for regeneration to occur. Okay, then you can use it for mucogingival recessions, mostly for Miller's class 1 and class 2. I'm not going into details again, just in a simple terms, if it's a very small recession, okay, very small recession for those who do not grasp what Miller's classification is, where let me say that it's a very small recession. In those cases, you can attempt to do the coverage by using a coronally advanced flap with that. But please understand that again, you need to have a zone of keratinized tissue. If you're trying to attempt the same thing on a completely a tooth with full of alveolar mucosa and zero keratinized tissue, nothing is going to happen. PRF itself, it's not going to regenerate or create keratin oocytes. It's not going to happen. PRF assets, it's not going to generate osteoblasts. Not going to happen. They are basically going to call these cells to these sites with the help of these growth factors. Like we said, you have your PDGF, you have your vascular endothelial growth factors. All this will enhance the blood supply there, and they will call these sites, cells to these sites to cause the regeneration there. As such, they do not have. as such they do not have. Okay, so please understand there is always a case criteria. The case selection is very important. You cannot just go put this in a Miller's 4 recession and expect the recession to be covered. It's not going to happen, because the recession is beyond the mucogingival junction, no keratinized tissue, nothing is going to happen. It's going to be a failure. Okay, then you can use it in implant dentistry, guided bone regeneration. Very, very important, especially those who are practicing implant, to prevent the dimension of the extraction socket. For example, imagine this is your extraction socket. You have your intact buccal, intact lingual wall. You can pack the site with your PRF and put a membrane on top and close it. So the membrane, what it does, you should understand there's a concept here that this always, the soft tissue here, the cells of the top soft tissue, that is the epithelium, they are the fastest migrators. So wherever you have a wound, the first thing that are going to go into that site is your epithelium. If the epithelium goes into that site, then there's no space. In simple terms, there's no space for the osteoblast or any other cells to come there and cause regeneration. So our aim first is to provide an area where there is growth factors with cells. And the second most is to inhibit this epithelium to come into that site. So that can be done by using the PRF as a membrane, or you can use GTR. But the advantage of using PRF for coverage, sometimes you will have such big sockets after you expand the buccal and lingual cortex, the sockets will be very big. Now, to get a primary closure, it won't be possible in most of these cases, okay, because you won't be able to approximate the two ends, the buccal and the lingual flap. You won't be able to approximate it. In those cases, PRF will play a very important role. So in the socket, you have an intact buccal and lingual wall. You place the PRF plug. Like I said, you make the plugs, place it into the socket, and then use a membrane to cover and then suture it. So what does the membrane do? It will prevent the epithelium from growing into the bone. Thereby, you're giving the space in that area for the bone to grow in. Okay, so that is the advantage of guided bone regeneration. Now, it can be used for management of extraction socket. Very important for students who are just passing out, because you're going to go out and do a lot of extractions. And I'm sure that when you do a lot of extractions, you're going to have lot of complications. You're going to fracture the roots, then you're going to dig in, try to take those roots out. You're going to fracture the buccal wall. You're going to cut here, there, everywhere, soft tissue tear, everything. Now, what is the problem with this? The patient will come back to you with dry socket. Okay, because it's such a traumatic procedure or severe pain and inflammation. Now, a study has been conducted where they did a two-arm study, and in one site, in these cases, they have used PRF membranes to close those sites with these gel in them, and one without them. And what they saw in that study is those patients where the PRF membrane was used, the patient reported very little post-operative pain or the dry socket occurrence. Whereas on the other arm, you had high chances of dry socket and patient returning back with pain. Okay, so this becomes a very big tool for you in your practice, where you can, because everything is easy, all you need is a consent from the patient for the blood. As soon as you know that it has become a traumatic procedure and you are anticipating something, a painful post-operative healing for this patient, pack the site with PRF. Here, you're not trying to regenerate anything. All you're trying to do is that to reduce the pain for the patient and reduce the chances of development of dry socket. Okay, how is this happening? Which cells play a role? Again, we talked about it, leukocytes. Why? Because they have anti-infection or strong immune response cells which are present there, which can clear out all the bacteria. And we study that it does a very good soft tissue healing. So again, please understand, in these things, it will help you a lot. Okay, then for my maxillary sinus floor elevation procedures, they are using PRF. For endodontic applications and even for pulp capping, they are doing it. Okay, so I'm not going into the details of that because I don't do any of that. All we do here is mostly perio procedures. Okay, so this is the application in the field of dentistry. Now, just coming to certain pictures, these are taken from the textbook that I just explained. So just to give you an idea, and then I'll show one or two cases that we have done here. But again, the quality of the pictures and everything is difficult because I have only one assistant. So on and off, we try to take some pictures. So here you can see socket preservation that is done. See, the primary approximation is not possible. So they have plugged the socket with PRF, and then they have placed a membrane here, and then membrane is your PRF membrane, and then sutured it. Just crisscross sutures so that it is nicely placed in there. See, the biggest advantage, if you place a GTR membrane like this, it will get infected and the whole site is going to get infected. But in case of a PRF, this is a big advantage that you have. And then you have excellent soft tissue healing that I don't know how to explain it to you guys. When you use it, you will feel the difference after a surgery. You will feel the difference when you are using PRF and when you are not using PRF. Okay, so you have excellent bone fill. Mostly the dimension is maintained as such, and then you can place your implant. It can be also used for recession coverage. So mostly we use connective tissue graft with coronally advanced flap. That is the gold standard. That still is the gold standard. Okay, nothing can beat that. So there are cases and there are studies I have done for a single tooth with gingival recession, which I have got a good result, but it's not necessary that always you should get. But with connective tissue graft, it is almost guaranteed because you have the tissue that you're providing there. Here, what you are expecting is, see, the recession site is opened. It's a initially a full thickness, and then you do a split thickness flap towards the back. You loosen the flap so that you can coronally position it, try and adjust and see if it is coming in position, and then you place, look at this membrane that has been placed into position. So it's completely covering the recession site, and then this flap is then sutured back, coronally advanced flap sutured back into its position. This is the result that they have shown in that book. It's an amazing result that you see, but again, the biggest takeaway point here is that you should have a good zone of keratinized tissue. If it is fully alveolar mucosa, you are not going to get this result. Okay, this is a single tooth case, single tooth recession. Again, you can see here a good thick band of keratinized tissue attached gingiva that is present here. So they have done this, and look at the result they have got here. Okay, so you can get excellent results based purely on your case selection. So if your case selection is good, then you will get good results. Okay. This is a case that we did here. This case was referred from endo with the chief complaint of mobility of this 1-1 upper central incisor, almost grade 3 mobile, depressible in socket. When a detailed history was taken, IOP and everything was taken, the patient had a history of trauma. And 15 years back, they had done a root canal treatment with an episectomy. When we saw the IOPA, we saw some kind of radio opaque material in the apical end of the root. And there was a big mass. I don't know if you can appreciate it, a big discolored mass at the apical end of that. So a re-RCT was done, and it had an perio component also. Along with the endo component, it had a big perio component that it had a mesial pocket of almost, this is a UNC 15 probe. So you can see up to 10 millimeter marking, it has gone inside. So here you can see the defect here. It's filled with granulation tissue now. It's just exposed. This whole thing was a big defect inside. So once we exposed the flap, we found a big mass of tissue here. We sent that for biopsy, curated out all the other areas, the tissue, filled this area with bone graft, and then I packed the whole site with PRF. The other thing which we did is also, there was trauma on this tooth from the lower anterior. So we relieved that also prior to the surgical procedure. And then you can see the bulkiness of the tissue once you pack completely with PRF. Look at this tissue here. And this is approximately, I think, 15 days or 10-15 days after suture removal. You can see the amount of healing that we got in that patient was excellent. The patient had only one criteria, that she wanted to save the tooth. Aesthetics was not a problem, nothing else. So we didn't worry about gingival recession or coverage or anything. All the patient wanted was to save the tooth. So basically we combined with the endo department, and now this patient is almost in a 1-year follow-up with excellent results. Pocket depth somewhere around 4 millimeter. So it is stable now. Patient is on a regular follow-up routine, and it's well maintained. Okay, so this is one case. Then these are cases from my PG also I've taken, because I don't have much photos from my time. So these are in intra bony defects. We have directly packed PRF and placed. Again, we have got good results. In furcation areas, you can see grade 2 furcation areas, you can again pack with PRF. This is again a furcation defect with the circumferential bone defect also. So what we did in this case is we filled it with bone graft and then covered it with PRF and sutured. Okay, so you get, if you select your case nicely, you will get good results. Now what I've started doing here is also for cases that we are doing for ortho, like canine exposures, impacted central incisors, when we are doing closed technique approaches for kids especially, to reduce their post-operative pain, we are packing the site with PRF. Just a little bit of PRF in that site, and the results that you get is excellent with that. Okay, so the post-operative pain, the patients that give after that is excellent. Even ortho department now, what they are planning to do is post extraction of premolars, they are planning to do this. So what I'm saying is that the opportunities for you to do your studies, especially PGs who are there, it's wide open for you guys. You can take a lot of angles in this and take up your studies and do a lot of studies on this. And once you have good results, a genuine study that has been done with good results, it can be forwarded in our group so that all of us who doesn't have the opportunity to do studies, we are doing it based on our clinical guidelines. Whatever we get, what we see in our clinic, in our patients, based on that we are operating and we are moving forward. But it is not what you say, purely evidence based on studies that we have read, but not studies that we are doing here. So you have the opportunity to do that. So coming to the studies which are there, basically from a perio point of view, lot of meta-analysis and systematic reviews have been done, and the conclusions that I would like to draw for perio point of view is that PRF promotes periodontal and soft tissue repair. They say that when you use PRF in conjunction with your open flap debridement, the improvement in pocket depth, clinical attachment level, gain, and your radiographic fill is statistically much more as compared to open flap debridement alone. So there is an advantage when you're using PRF. Also, when you use in 2 to 3 wall defects and for class 2 furcations. Again, like I said, case selection is very important. You cannot, for example, also for guided bone regeneration. Like I said, you have the buccal wall, you have the lingual wall. Imagine you have done the extraction and you have destroyed the buccal wall. You have only one wall here, you are packing PRF, and if you are expecting the dimension of this ridge to be same, it's not going to happen, because already you have destroyed this wall. The epithelium from this side is going to grow inside it and you're not going to get a good result. So case selection is very, very important. Okay. Now, just to give you an idea where PRF is in the field of medicine also, because they are also advancing, they are using this in a much larger field. Okay, so they are used in facial aesthetics and rejuvenation, especially IPRF. And I see that most of our alumni who are working in facial aesthetics, they are still they are using good amount of PRF. Then you have for chronic leg ulcers, especially in diabetic patients. This is again a case which has been depicted, which they have done. This is one of their first cases Chowkaran had done, and the results they have got. It was a chronic non-healing diabetic ulcer. Look at the membranes, they kept placing, giving dressings, and after a period of time, they got excellent healing. Concept is again same. PRF has cells, they have growth factors, especially vascular endothelial growth factor, which will allow more blood vessels to come there and help regeneration and closure of the wound. Okay. PRF is also used for chondrocyte regenerations now, for ligaments and tendons, and in orthopedic medicine. Okay, so these are the applications in the field of medicine. These are the references. This is the textbook that I was talking about, textbook of platelet-rich fibrin in regenerative dentistry. An excellent textbook for you to go through it. And they have enlisted n number of studies about the number of leukocytes counts, how it's increasing based on your low centrifugation concept, based on horizontal, everything they have written, and you can take the articles from there. So all these articles that I've mentioned there is mostly from these textbooks, which are very relevant, and it gives you an insight on where the studies are going, and you can practice evidence-based dentistry. Okay, so see if you can get hold of this textbook, and you can go through the whole book. Chapter by chapter, they explain about recession, then bone grafting, then about extraction socket, sinus floor elevation. Everything is explained chapter by chapter. Okay. So thank you so much for your patient listening. If we have some doubts, we can just take that now. At least from what I can tell, I'll be able to clear it.
Thank you, Jerry, and congratulations for explaining the mechanism and applications of PRF in a very lucid manner. I'm
Thank
sure
you, ma'am.
our students and all our, people who have participated have understood it very nicely and would like to try it out and, use the applications in their day-to-day practice. At this juncture, I would like to take any questions from the audience, if you have. Yes, please.
Thank you, sir, for giving us an insight into PRF.
Thank you.
I would like to ask one question. Sometimes when we draw blood and we send the vials for PRF, sometimes that PRF does not form. Like, what can be the reason? Is it the vial or?
No, you have already explained the reason. You are saying you're sending the test tube. You have already lost enough more time. By the time you're sending it, where are you sending it? The machine should be next to you.
Okay. We don't have that provision sometimes, like it is in the next department. So is the time elapsing?
See, the more the extraoral time is there, especially if you're using an open test tube, more extraoral time you have, the more failure rate, or what you say that the more chances that all your leukocytes and platelets are going to go down. The whole concept that I explained is that time is very essential. If you are going to, because as soon as the blood comes in contact with the glass, and if it's an open test tube, if you're using an open test tube, it's oxygen from the top, it's going to start clotting. And once it starts clotting, you are not giving the cells enough time to travel up into the PRF gel. And what happens is once it clot, you won't have enough plasma to, by the time you start centrifuging, enough plasma won't be formed. And that is why you are not getting a good quantity of your PRF. And the test tubes, like I said, you have to use the right test tubes. If you're going to load your blood into a green, white, blue test tubes, which are actually meant for IPRF, you will never get a gel. You'll always end up having a liquid-like consistency. You understand? So time, extraoral time, the test tube that you're using and the centrifuge that you're using is very, very essential for this.
We are using a vacutainer only. Like, I want to know till what time we can, you just said as soon as we draw the blood.
Yes.
We should.
What we do is that from here, as we take the blood, my assistant will be standing with the centrifuge open and it goes inside. And then it closes and the process starts. The more time you spend, the more it's going to sit and clot. So you won't get good results.
Okay, sir. So how much RPM do you suggest in your daily
How much?
practice?
See, yes. I'll come to that. For me, we don't use based on RPM. Okay, another thing I want to say, nowadays the concept of RPM is thrown out. Now it's RCF, that is relative centrifugal force, or now they based on G forces they are talking. So don't use that terminology anymore because RPM is old trend. When we talk about PRF now, we talk about RCF or G force. So if you've seen my chart there, you can see initially it will be RPM, and then it will comes in grams, 200 grams, 700 grams, 60 grams. It will be like that because now the concept is G force. And with the new machines that we are using, I'm not at all bothered about that because everything is preset. So you have to just place the test tube in that, select what you want and just spin it. It will do on its own. From academic point of view, if you're going to write an MDS entrance exam or you're going your PG preparing for a final exam, yes, you have to by heart everything. But for me as a clinician, I don't by heart it anymore. I have my settings there. I just place in it. And even I don't do it anymore now. My assistant is trained for that. So she does everything. She places it, she selects it, and then I just go for the procedure because I'll be operating there at the same time.
Okay, sir. Thank you, sir. You just mentioned that PRP is first generation and PRF is second generation. And many people in facial aesthetics, they are doing PRP in face. Like that is what they call the vampire facials. So what is better, injectable PRF? Or because I've not heard many people doing injectable PRF here, mostly they are injecting PRP. So what is your take on that, sir?
Okay, I am not into facial aesthetics, but based on the theory, I can tell you that injectable PRF will be better. Okay, based on the theory, but somebody who's been practicing in facial aesthetics, they'll be able to give you a better clinical point of view. But from what I have studied and what I read on the articles, what I just explained to you, what do you need there? You need all your cells there at the top. When you're using PRP, you are using first of all an anticoagulant, so you have an additive now. So that, as studies have shown, that hampers the healing of the tissue. So when you compare all these things, I think injectable PRF will give you a better result. But again, that is not my field of practice. So clinically, I cannot tell you what is the result outcome that comes. But academically or scientific basis, evidence based, what we see in journals, IPRF will have more cells, will have more concentration of platelets, leukocytes, and growth factors. And the advantage with this advanced centrifugation machine is that these growth factors are released over a period of time. PRF, what they show is that the graph, there's a sudden increase of, PRP, there is a sudden hike of growth factors, and then it just drops down. So there's no sustained release of growth factors. What we need in a healing site is that you need a sustained release. So PRF, that is APRF and APRF plus, they say that around 10 to 14 days you have sustained release of growth factors. So based on all that, I think IPRF would be better.
Thank you so much, sir.
Yeah.
Do we have any more questions from the online participants? Okay, so if we do not have any questions from the online participants, I have here with me Dr. Joseph, who's an oral and maxillofacial surgeon, and as far as my knowledge goes, who was using PRF as his thesis project. So based on your experience, would you like to add anything?
Thank you, ma'am. And thank you, sir, for the excellent presentation. And PRF is something that's close to my heart, and it was such a joy to hear all
Same
that.
Same here. It's very close to my heart also.
And so I just wanted to add few things. You've covered the perio part, and here in our department, we have been working with APRF. And something that we are doing newly is we've been putting it on facial defects, and we have seen excellent results on the face. Around 3 cases we did in the last 3 months, and even sir would like to add, I think.
Is it open wounds? You're placing it on open wounds?
Yes, sir.
Yeah, so it's basically like a diabetic non-healing ulcers, same concept you're using. Yeah,
yes, exactly. Sir. And we've been trying to educate our medical counterparts also. Just last week, I placed APRF in non-healing leg wound in one of the peripheral centers.
Yes. There are a lot of studies on that.
Yes, sir. So we've been doing this, I think, for the past 6 to 7 months, and we have seen excellent results. And apart from that, even in sinus lift and all, we've been using IPRF with bone graft as one of our thesis. I think sir would like to add something on that in the Jyot, sir.
Just few days back, I did a closure of oroentral fistula with PRF, membrane and fibrin rich. And I gave a triple layer closure for that. First, I did the fistula removal, and then I closed that and put the PRF on it. And then I gave a PRF membrane, and then I gave a soft tissue closure. So it is a triple layer closure which I have executed very nicely. Let's see what the results will be. I will definitely share with you.
Yes, sir.
And,
yes, sir. Sir, I think it's also a good opportunity for us, like especially as CDC, when we have our PGs, there are so many areas that needs more study, especially in post-operative pain and everything, because I was Googling and trying to get more articles on that. Post-operative extraction, double arm studies, very few are there. So I think we have a good opportunity for that. For us, the problem is case selection in perio is a very big problem. If you don't take the right case and then start doing things, you don't get a good result. But for extraction sockets, traumatic extraction sockets, and I think we do get a lot. So, and it's easy to apply in those cases.
And as Joseph said you, that we have been, as you know, you have been working with us in trauma center also, and you have been attending the calls. So now we have tried to put on some facial lacerations where
Okay.
closure has not been done or the wounds are abraded, like road traffic accidents, where
Yes, sir.
lot of abrasions are there with tissue loss. So over there, Dr. Joseph has put some PRF membranes and have been packing it and regularly following up after at least multiple PRF. So that
Okay.
defects have been really come up very good. And this time we are going to present, he is going to present this in the annual conference. He has
Okay, sir.
already sent a paper and he's going to present this in the annual conference. And if it works up nicely, we are actually going to go ahead with it in other procedures also. Let's
Yes, sir.
hope for
Yes, sir.
the best. Thank you,
Yes,
Jerry.
sir.
Thank you so much.
No.
God
Yes, sir. Yes,
bless
sir.
you. You are the
Thank you, sir.
shining star of our CDC and keep shining like this. My blessings are with you.
Thank you, sir.
And
Thank you.
I really feel good when I heard it and I saw your brochure on the our CDC faculty, and I am personally circulated everywhere where it was required to be done, and I am thankful you took a time and did this presentation. Thank you so much. Over to Dr. Ritu.
Thank you, sir.
Thank you, Dr. Inder. Do we have any more questions from the audience?
Yeah, if the chair would permit me, I'd not like to ask some question. I like to add my bit of experience to PRF. I'm
Sure,
Dr.
please go
Rahul, the
ahead.
batch of 98.
Please go ahead, Rahul.
Yeah, so one of the student asked that we are not able to get a good quality PRF. And as Jerry rightly mentioned, that the most crucial part about making PRF is time. So from the veiny puncture to the actual use of the PRF, it should take less than a minute. If the more extraoral time you use, the quality of the growth factor release will reduce. And the second essential component that I'd like to add is most of us in our remote locations, we do not have that PRF box. But what Chokron's protocols mentions is that you need to have that box because when we compress it for the membrane, if you are doing it with any other any other instrument apart from the PRF box, you will leach out the growth factors outside only. So use of the right armamentarium for making PRF membrane is also very essential. And not only perio, Jerry, but right now for tissue adhesives, for wound dressings, like the Dr. Joseph here mentioned, it is becoming very versatile now. And we now use the term platelet concentrates. We started using APRF and all that, but we now the generic term is platelet concentrates. So for the PGs who are here, you need to understand that there'll be vivas based on these questions if you're a PG, and there will be academics which will be memorizing all those protocols in it. But as a clinician, we forget all these things. But since there are PGs and undergrads here, so memorizing the Chokron's protocol, which year, memorizing something called as a pass principle for regeneration, that all things will be essential. So that was my few penny pounds of wisdom I have gained in my PG days. Thank you.
Thank you, sir.
Thank you, Rahul, for sharing your pearls of wisdom with us. Any further questions? So if there are no questions, we can wind up this session. First of all, thank you to Jerry for taking out time and preparing this presentation and sharing this presentation with us in a very practical and very easily understandable manner. Thanks to all the participants for joining us today for this session. And thank you to Principal Sir and the team who have arranged this Code Christians for the benefit of all the Christians and all our students. Thank you once again and have a good day.
Thank you.
ma'am. Thank you.
Thank
Thank you
you,
all. Thank you,
Jerry.
sir.
And
Yes,
thank
sir.
you, Joe, for coordinating this. And thank you for all the alumni who joined. Okay, thanks.